You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for December 4th, 2020. This week, COVID vaccines, and much more from the AHA, including surrogate endpoints, MRA inhibition, type 2 MI, coronary CTA, and SGLT2 inhibitors. As far as COVID goes, earlier this week I thought cases were going to trend down, like they were in much of Europe. But now, a week after Thanksgiving, cases are reaching new highs. 2 weeks ago, I spoke of a tripling of our case volume at my hospital, and we've sort of stayed at that level, but we worry about the coming weeks. Now, the thing I have well learned from this surge is how hard it is to care for these COVID patients. Procedures are harder, basic care is harder. The staff on the COVID units they work so darn hard. Every day seems like a slog. People are fatigued. You can see it. You can feel the fatigue. Now, as for good news on vaccines, on Wednesday morning of this week, the UK government announced that they've approved the messenger RNA vaccine from Pfizer and they plan to begin shots soon, which is huge news. Our FDA meets soon to review both the Pfizer and Moderna vaccine, and approval seems likely. Vaccine development for this virus has been a sheer triumph for biomedical research. Now also, over the past 2 weeks since we last talked, the Oxford team issued a press release on the AstraZeneca vaccine. Now this vaccine uses a modified adenovirus vector. It's different, and it does not require storage at freezing temperatures. Now the results were positive, but a little bit more peculiar. I say peculiar because unlike the two messenger RNA vaccines, which came from single large RCTs, the AstraZeneca vaccine data comes from two separate studies, one in Brazil and one in the UK. The two trials differed slightly in methods. They did not use a standardized dosing regimen and had different control injections. The other peculiar issue is that efficacy of the AstraZeneca vaccine looked better in a smaller group of patients who accidentally received half the dose of the first shot. We'll have to wait for more data and regulatory review of this vaccine, but it simply doesn't look as good as the messenger RNA vaccines. Now, a note on vaccine acceptance and science appraisal. One of the issues that will arise is when a person has an illness after getting a vaccination. Not just fever or aches, but say a stroke, MI, or some neurologic event. Humans are causal inference machines. The temptation will be to think the vaccine caused the issue. Now, since the vaccine will be given first to patients with comorbid conditions, it holds that many people will have illness events that occur temporarily after their vaccination. Now, add in social media. Let's say a number of these events go viral. I worry that these will affect vaccine acceptance. And herein lies one of the reasons to be so critical of scientific studies. That is, when journal editors, peer reviewers, key opinion leaders allow and promote flawed data, which is then amplified in media coverage, people get the sense that A, science is less about truth and more about attention, and B, the important distinction between association and causation gets further blurred. Thus, in my opinion, every time a howler study gets published without a critical review, trust in science goes down. And the paradox, I think, is that by creating doubt in science, especially when it comes to causal inference, we may increase trust in its value, which is needed now more than ever. Okay, now to some more news from AHA. Recall that 2 weeks ago, I discussed the Samson statin nocebo trial, the fish oil controversy, and two studies on early AF ablation. There were other notable studies. AHA included a resuscitation symposium. I want to briefly discuss a study presented there as a late-breaking trial to highlight the problem of using surrogate markers as endpoints. Now, comatose patients who have just been resuscitated from an out-of-hospital cardiac arrest surely have high levels of inflammation, and high inflammation could worsen brain recovery and negatively impact cardiac function. Tocilizumab is an IL-6 inhibitor that reduces one aspect of inflammation. Early on in the COVID pandemic, there was excitement about using the drug, but an RCT called the BACC trial, which was published in New England Journal, found no difference in the rates of intubation or death with tocilizumab. But note the endpoints of that trial, intubation or death. Well, a group from Denmark studied the use of tocilizumab in comatose patients after cardiac arrest. And the headline was that there was a, quote, very dramatic effect of the drug on the primary endpoint. And that sounds great, but here's the problem. The primary endpoint was levels of CRP. Yes, CRP was 84% lower in the treatment arm. Cardiac enzymes were also lower with tocilizumab. The lead author said in a news story that this trial demonstrated the feasibility to reduce systemic inflammation after out-of-hospital cardiac arrest. And I mean no malice to my colleagues in Denmark, but I am not sure that this late-breaking trial of 80 patients tells us anything useful. Yes, it is a positive study, but there is only one important outcome for patients in a coma after a cardiac arrest, and that is meaningful neurologic recovery. Does showing that a drug that reduces a nonspecific marker of inflammation give us any info to spend further dollars and time on a larger trial? Now, I don't know the answer to that question, but I do know that tocilizumab is a costly drug with risks of secondary infection. Evidence for its use ought to include studies powered to assess clinical outcomes, not nonspecific biomarkers. My friends, always look at the primary endpoint of studies. Surrogate markers can be useful, but far better is to measure the actual desired clinical outcome. I've yet to meet a patient with serious illness who actually cares what his or her CRP is. Next topic. There is another potential new drug coming to diabetes, renal, and cardiology clinics. Finerenone is a mineralocorticoid receptor antagonist, but unlike spironolactone and eplerenone, finerenone is a non-steroidal blocker of aldosterone, and this is a huge advantage. The Fidello-CKD trial, which was presented at a kidney meeting and published in New England Journal of Medicine, enrolled about 5,700 patients. These patients had chronic kidney disease and type 2 diabetes. It was finerenone versus placebo. Nearly all of these patients were already on RAS inhibitors. The trial measured a composite of renal outcomes as a primary endpoint, but the authors also collected cardiovascular outcomes. In the main trial, finerenone resulted in an 18% relative risk reduction in the composite of kidney failure or a decrease in eGFR from baseline or death from renal causes versus placebo. This 18% reduction was statistically significant. The secondary outcome was a composite of CV events, and in the composite of CV death, MI, stroke, heart failure, finerenone resulted in a 14% relative risk reduction versus placebo, and that hazard ratio of 0.86 had confidence intervals of 0.75 to 0.99. Hyperkalemia was more common with finerenone, 2.3% versus 0.9%, but that 2.3% is much less than was seen in trials of spironolactone in sicker patients. At the American Heart Association meeting, we heard more details about the cardiovascular outcomes in this trial. Circulation published this Fidello-CKD substudy, and it looked at the rate of CV events according to having a history of heart disease at baseline. In other words, was the drug finerenone more effective in patients with known heart disease? The main finding was that finerenone reduced cardiovascular events by 15% in patients with known heart disease and 14% in those without heart disease. The p-value for interaction was obviously not significant. Now, interestingly, The authors also reported renal outcomes based on the presence or absence of heart disease. Finerenone reduced renal outcomes by 30% in patients with heart disease, but in patients without heart disease, finerenone did not result in a significant reduction of renal events. I'm not sure what to make of this. I'm not even sure if it was a pre-specified analysis, but it is surely plausible that patients with chronic kidney disease and diabetes and heart disease benefit more from the drug than those without heart disease. The incidence of hyperkalemia was elevated, but to a similar degree in both patients with and without a history of cardiovascular disease. The makers of finerenone, which is Bayer, they've submitted a new drug application to FDA, and I'm betting that we have a new drug on the market. Journalist Mitchell Zoller has excellent coverage, and he notes that we will soon have results from another major randomized controlled trial called the Figaro DKD trial, which will enroll a similar patient population, but this trial will measure cardiovascular outcomes as the primary endpoint. Next topic concerns type 2 myocardial infarction. Gosh, there is so much confusion about MI. I couldn't resist talking about this topic again. The study in question, which was presented at HA and published in Circ Outcomes in letter form, came from a group at Harvard Medical School, and they studied the workup of patients admitted with type 2 MI at their center. The main question was how often these patients are evaluated by a cardiologist during the hospital admission and whether or not this changes testing and treatments. Now first, this podcast cannot emphasize enough the definitions of MI set out in the fourth universal definition. To review, type 1 MI, or a traditional heart attack, is defined by atherosclerotic plaque rupture. This can be a STEMI or non-STEMI, but it is an acute coronary syndrome from plaque rupture. Type 2 MI is everything else. It can be acute myocardial ischemia due to a mismatch in supply and demand, say from spasm or dissection, tachycardia, anemia. It can be due to acute myocardial injury due to things like myocarditis, Takasubos, ablation, ICD shocks, acidosis, pulmonary embolism, even strenuous exercise. Or type 2 MI could be due to chronic myocardial injury due to heart failure, chemotherapy, infiltrative disease, and CKD. The key concept is this. Patients with type 1 MI due to plaque rupture should be admitted and treated by cardiology, often with early intervention, especially in the setting of STEMI. But patients with type 2 MI, which are the majority of patients, should be treating the underlying condition. Okay, now to the study. The authors did chart reviews on 359 patients with type 2 MI at their hospital. 57% were seen by a cardiologist, 43% were not. Patients seen by cardiology obviously had more risk factors, and they were more often had abnormalities on echocardiography. I'll give you the results as ordered in the research letter. The order is somewhat peculiar. First, patients seen by a cardiologist had more stress testing, nearly 5 times more echoes, nearly 4 times more, and more coronary angiography. But there was no difference in all-cause mortality in the cardiology versus the non-cardiology group. Patients seen by cardiologists more often received statins and beta blockers and clopidogrel, but there was no difference in the use of RAS inhibition. Now, only a little more than a third of patients had outpatient cardiology follow-up, and those seen by cardiology in the hospital were more likely to have cardiology follow-up. Well, here's where it gets interesting. The authors cite a paper from 1998, that found an association of cardiology care and lower in-hospital mortality from MI. And they then conclude, quote, our analysis raises the possibility of gaps in care for patients with type 2 MI. With all due respect to the authors, that's a problematic conclusion. You can't cite a flawed paper from 1998. In that era, most MIs were type 1 MI due to plaque rupture, and of course, those cared for by cardiologists did better. Now, with the advent of higher sensitivity troponin assays, most MIs are not due to plaque rupture. They are type 2 MIs. Since the therapy for patients with type 2 MIs means treating the underlying disorder, which is often not cardiac, I would make the case that many patients would do better without cardiologists. Why? Because in my experience, cardiologists can often have a narrow focus. For example, the heart, or more specifically, the coronary arteries. But what most patients with type 2 MI need is a doctor who sees the whole scenario. That is often not the cardiologist. Isn't the main finding of this paper that, quote, there was no difference in all-cause mortality in the cardiology versus non-cardiology group? So my take-home, please, my friends, help me change the thinking about myocardial infarction. Patients with type 2 MI are not the same as type 1. Patients with type 2 MI need a clinician to think, what is the underlying cause, and then treat that underlying cause. It is often not the heart. Next topic, coronary CTA. The ischemia trial's use of coronary CTA has surely accelerated use of this imaging test. Even I recently ordered a coronary CTA on a patient. This imaging test has predominantly been used in patients with chest pain and a lower risk of CAD. The rapid CTCA trial performed in Scotland was a pragmatic RCT that studied about 1,700 patients who presented with chest pain but had higher risk. The higher risk was defined by three things: elevated troponin, or ischemic changes, or a history of known CAD. The primary endpoint of this trial was a good one. It was all-cause death, or MI. And the primary endpoint occurred in 5.8% of the CTA group and 6.1% of the control arm. No significant difference. The CTA group was associated with longer hospital stays and greater cost. There was interestingly less coronary angiography, but there was no difference in coronary revascularizations in the two groups. The authors concluded that these findings do not support the routine use of early coronary CTA in intermediate or high-risk patients with acute chest pain. One interesting side note was that 52% of the patients with high-risk features, ECG changes, troponins, or known CAD, did not have obstructive disease. I highlight this study on the podcast because so much of the challenge of modern cardiology is not can we do something or can we image something, it's should we do something or should we image something. And cardiac imaging can be extremely useful, but patient selection is key. Now the final topic, AHA has brought more good news on the class of drugs of the SGLT2 inhibitor drugs. Sotagliflozin is the newest kid on the block. The twist with this drug is that it blocks both sodium glucose cotransporter 2 channels in the kidney, but also SGLT1 channels in the gut. At the AHA meeting, we learned the results of 2 RCTs of sotagliflozin, and New England Journal published both of them. Soloist WHF randomized about 1,200 patients with type 2 diabetes who were recently hospitalized for heart failure. The primary endpoint was CV death and heart failure, and the trial ended early because of loss of funding from the sponsor. The drug was started during the hospital stay in about half the patients and within 2 days in the other half. The rate of the primary endpoint was significantly lower in the sotagliflozin arm. It was 51 versus 76 per 100 patient years. The hazard ratio was 0.67, so it was 33% relative risk reduction, and this was statistically significant. Now, like it has been so with so many other SGLT2 inhibitors, the primary endpoint was driven by lower rates of recurrent heart failure. CV death and all-cause death trended lower but did not reach statistical significance. The key feature of the Soloist trial was the efficacy of the drug with early initiation during the hospitalization. Now, the second trial is called the SCORED trials. This enrolled about 10,000 patients, again, type 2 diabetes and CKD, and the GFR ranged from 25 to 60. These patients also had risk factors for CV disease. They were randomized to sotagliflozin versus placebo. And again, the primary endpoint was similar, CV death and heart failure. The primary endpoint of this trial was changed slightly during the trial owing to loss of funding. Once again, the drug reduced the primary endpoint. The hazard ratio was 0.74, so a 26% reduction, and the confidence intervals range from 0.63 to 0.88. And once again, the composite was driven by lower rates of heart failure, not so much for CV death. Now, in both trials, the rates of diarrhea were higher with the drug, and this is possibly due to its SGLT1 activity. In the SCORE trial, DKA occurred in 30 patients on sotagliflozin and 14 on placebo. I was researching this and I learned that the FDA rejected sotagliflozin earlier this year for use in patients with type 1 diabetes, and this was due to DKA concerns. The loss of funding in these trials led to internal validity concerns. The authors laid out these in their manuscripts. There was a change in endpoint, there was difficulty doing adjudication of events, and about a third of heart failure admissions were not confirmed to be primary events, and this led to an overestimation of the number of events. Some other notable findings mentioned during the AHA presentations: in SCORED, sotagliflozin was able to reduce the hemoglobin A1C substantially across all levels of CKD, even in those with an eGFR less than 30. That's big news for primary care docs and endocrinologists. And then for patients with heart failure with preserved ejection fraction, there may have been a signal of benefit. The two studies together included 739 patients with HFpEF. The combined analysis showed that the incidence rate for the primary endpoint was reduced in absolute terms by 11.6%, by 37% in relative risk reduction, a number needed to treat to prevent one event of 9. Now, this was a non-pre-specified post-hoc analysis, but based on the oodles of data from previous trials, this seems like a plausible finding. I had a patient recently with diabetes and heart failure with preserved ejection fraction, and I was thinking SGLT2 inhibition. Trial discussant Dr. Jane Wilcox had some nice slides outlining coming trials with this class of drugs in patients with HFpEF, and I'm optimistic. Now look, both these trials had some imperfections in their conduct due to loss of funding, but this data is consistent with prior data with this class of drugs, and I suspect FDA will approve sotagliflozin for these indications. It's certainly an encouraging class of drugs. And so that's it for this week in cardiology. As always, I'm grateful that you listened. And remember, please, if you like this podcast, consider taking the time to give us a rating or writing a review, as that helps others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.